Your class gift is not going to be something you buy, but something you do. Like fix the chairs in here, right? Yeah, that would be a fantastic class gift. All right, so let's get rocking and rolling here. I'm going to pull up slides here real fast. How's everyone doing? Everyone doing okay? I'm tired. You're not okay? Why are you not okay?
Exhaustion is setting.
I agree. I agree. And, like I mentioned last semester, this semester has its own unique set of challenges. It really does. And I think you guys are seeing some of those challenges right now. So it's a lot of midterms, it's a lot of tests, it's a lot of material, it's a lot of studying, it's a lot of fill in the blank, right? It's just a lot. All right, so I have very, very good news. We are done with the viscera. Woo!
Except for our lab.
Except for the lab. That was a collective groan. That was hilarious. That was great. All right, so we are going to move on to the hip. This is where the course is going to shift gears dramatically. You probably saw a lot of overlap between acute care and this course. Now we're going to see a lot of overlap between biomechanics in this course. That's a good thing. That is a good thing, okay? We're also going to see a lot of setup for next year when you guys take gait and movement analysis. The lower extremity, we're going to see a lot of patterns that mimic the upper extremity. What makes the lower extremity a little more difficult is the fact that, number one, now we're going to add in weight bearing. Weight bearing is a big concept. Number two, we're going to see a lot more interdependence on the joints. So what we're going to see is what happens at my hip joint is going to directly affect my knee joint, which is going to directly affect my ankle joint, which is going to directly affect my foot joint, right? And think back to the old elementary school song, the hip bone is connected to the thigh bone, blah, blah, blah. It really is true. So that's one thing that we're going to start doing is we're going to start layering on concepts. So we're going to spend, and we looked at the syllabus, it looks like a lot of time at the hip, and that is done intentionally because we're going to go through a lot of these concepts very slowly so you guys understand them. Because once we get down to the knee, we're going to come right back to the hip and talk about what happens at the hip also happens at my knee, but in opposite directions, right? So it's going to get very confusing if we don't set that foundation well. So one of the big concepts, you guys probably saw this in the textbook, is weight-bearing support is one of the two big functions of my lower extremity. Obviously, everybody in this room, no matter what position you're in, is bearing some weight. You're either bearing weight on your ischial tuberosities right now. I'm bearing weight on my feet. But my entire lower chain is absorbing some of that force. Our hips are designed to bear weight. You guys have probably already seen from the reading and doing the homework that the hip joint has some similarities to the shoulder, but also has a lot of differences. My shoulder was made for mobility. My hip is made for stability. Okay? So number one, my hip is made for stability. Now what we're going to see is that stability is going to come from a couple key areas. The first key area is going to be the articulation of the femoro-acetabular joint, which is a really super duper fancy way for saying hip. The reason that I will use a term like femoroacetabular joint is because I want you to really understand that my hip is an articulation between my femur and my acetabulum. My acetabulum is going to be part of my pelvis, as we're going to see. So what's really interesting about the hip joint, the femoral acetabular joint to be more specific, is that what we're going to see is a really large cup. So at the hip joint, and we're going to get into this a little bit later too, I see a really deep cup that a head or a femoral head is going to fit into. So this being my acetabulum, and this being my femur, or femoral head. That's going to provide a lot of advantages. Okay, first big advantage it's going to provide is it's going to give me a lot of contact. Now, think back to a little bit of biomechanics and think back to the advantages that having contact area is going to have. And Chris is doing it with his hands. Force dispersion. Okay, so let's think about this. You know, who's seen the trick where the guy lays on a bed of nails? You guys ever seen that trick? Why is the guy not pierced with any one nail? Because the force is dispersed throughout the entire surface area. That's going to be a really interesting concept and a really important concept, especially at the femoral acetabular joint, because what we're going to see is depending on how my femur is made, because we're going to get into all those torsion concepts that we got into at the shoulder. If you guys remember retrotorsion and antitorsion and all that stuff, we're going to hit all that stuff again. Plus, we're going to add in, because my femur and my femoral head and my femoral neck are more pronounced than my humeral head and my humeral neck, we're going to throw in different angles, all right, valgus angles and varus angles. That will also affect the contact area. That will also affect how my femur is articulating with my acetabulum. So we have to understand how that joint's put together, and we have to understand that it all works under a concept of stability. So I need my shoulder to be very mobile. I do not need my hip to be very mobile. I need my hip to be very stable. The other big reason that I'm going to have a lot of stability at my hip is that I'm going to see a very dense network of ligaments. And in fact, I'm going to see 3 ligaments. We're going to draw them out here a little later. I'm going to see something called my iliofemoral ligament, my ischiofemoral ligament, and my pubofemoral ligament. When you guys get down to that section, you guys are getting into the hip joint itself. I'm not sure, Dr. Justice, can we disarticulate any of the hips? Or can we remove muscle? Can we remove like the 6 deep lateral rotators and stuff? Okay. So what?
You actually disarticulate the ones back there.
Okay. So then what I want you guys to do is, before you completely disarticulate, remove all the muscle surrounding that hip joint. What's number one is a chore, because there's a lot. And then take a look at how those ligaments are put together. Feel those ligaments, move that hip around, move it back and forth, and feel how tight those ligaments are. What you're really going to get a good sense of is how stable that joint is. Now, you guys talked about total hip replacements in acute care yet? No, you will. What?
Just precautions.
Just precautions. Ooh, I love hip precautions. All right. Let me ask you. What are the total hip precautions? Fantastic. Why are those the hip precautions? I'm hearing mumbling. Somebody stand up and speak for the group. So I don't care who does it.
Because that is where they place the incision, and that is the most likely place for that dislocation post-op to occur.
Part of it. That is part of it. Yep, and that's number one reason. The hip precautions are the hip precautions because of incision placement and risk of dislocation. Now, here's the other part of it. There's two other parts. Number one, and what we're going to see is that just like at my shoulder, I'm going to have a very dense capsule surrounding that hip. When an individual has a hip arthroplasty, they actually have to pop the capsule in order to get the hip and take it out. We're going to see that there's actually an area of negative pressure between the femur and the acetabulum intracapsularly. So inside that capsule, there's negative pressure. You guys know what negative pressure means? Vacuum.
Yes, they know because it's happening in their thorax with each and every breath.
Okay, well, it's happening. To be fair, you know, just because it's happening doesn't mean it's happening.
The lungs open.
Right.
That negative pressure inside there, right? That vacuum up against the walls of that thorax, the same thing's going on inside that capsule.
Exactly. So inside that capsule, there's a negative pressure that is sucking my femoral head to my acetabulum. When that individual goes through a total hip arthroplasty and they cut that capsule, they lose all negative pressure. It becomes neutral at that point. So you don't have anything sucking the femoral head to the acetabulum anymore. That's number two problem. Number three problem, this is why you have total hip precautions. And I'm gonna bring back an old term, an oldie but a goodie, convex concave. Yeah, we remember convex concave. Now, take me through those total hip precautions again. One at a time. Nothing above 90 degrees flexion. Okay. Number two. Adduction. Number three. Internal rotation. External for anterior. Internal for posterior lateral, right? So if we think about it, if this is my acetabulum, and that's my femur, femoral head, femoral neck, shaft of the femur. Towards my body's posterior, towards you guys is anterior. When I internally rotate that hip, what direction does my femoral head go? Goes posterior, right? So then my head of my femur, without its vacuum, is poking up against that incision. That's why they have that precaution, because now I just increase the risk of dislocation exponentially. When I do that anterior incision, so incision is right in the front, when I externally rotate, my femoral head goes what direction? Towards the front, where the incision is. Okay? So you have to understand how that arthrokinematic relationship happens in order to understand why those hip precautions are what they are. Okay? So I give Dr. Helms, I give that crew a lot of credit for going through hip precautions, but you have to understand why those are the hip precautions. Okay? Because what you're going to do is you're going to have to explain this to a patient who's just had surgery, right? And they're not feeling so hot. Here's the other thing. Okay? Have you guys discussed what side of the body the cane goes on? Ipsilateral or contralateral? Yeah, if we're doing a single point cane and giving a single point cane to a patient, does it go on the same side or opposite side? Or do we put it in the middle? Because I'm getting both answers, right? So we'll just split the difference, we'll put it in the middle, right? It was kind of used as a pogo stick, right? So, okay, so we got two options. We got ipsilateral and we got contralateral. And what we're going to discuss is we're going to discuss the forces that are going to happen. This is where a little bit of biomechanics is going to come in, because we need to discuss why that cane or that other device needs to go on the contralateral side. Okay, And believe it or not, this is going to be one of the more frustrating arguments you're going to have with patients. Because they're going to come in and they're going to slap that thing on the ipsilateral side because that's what they feel is best. You're going to have to convince them to put it into their opposite side, right? Non-dominant arm a lot of times, and convince them why, and then train them appropriately to use it like it should be.
It just replaces your stance leg when you're in the swing motion of fall.
That's exactly it. That's exactly it. And essentially what it does is it adds a base of stability and it adds another normal force in addition to the normal force that's happening at the hip abductors. That's where the biomechanics comes in. We'll get into that. All right, here's number 2. The other big function of my lower extremity is to move my butt around life. Okay? General locomotion. You will take an entire class on gait and movement analysis. It's going to be lots of fun. It's next year. In the context of this course, what we're going to do is we're going to start discussing how my musculature in my lower extremity is going to react and why it's going to react that way when I do something like, and this is where, this is going to sound weird. When I lift one foot off the ground, everything changes. This is where the lower extremity is going to become much more difficult than the upper extremity because I can do this in my right arm, ain't nothing happening in my left arm, right? But I lift my left leg off the ground, my right leg's doing a lot more work now. My left leg's still doing work, but my right leg's doing different work. So what we're going to have to understand is that there's going to be a relationship between my right and left sides here. One thing we're going to have to understand, you guys, I'm going to throw out a term, tell me if you've heard this one or not. If you haven't heard it, it's okay. You guys talked about this one yet? Trendelenburg gait, right? So what is a Trendelenburg gait? That sounds fancy. It's where your hip drops. You're not going to like my answer. Is the hip dropping? What's actually dropping? Who said pelvis? It is your pelvis. Okay, so this is a pelvic drop. This is where things get a little complicated. If I lift my left leg off of the ground, aka I go into a single limb right lower extremity stance. If I am going to expect a Trendelenburg gait to happen, which side of my pelvis is going to drop? Right or left? Is this side going to drop or is this side going to drop? This side? Okay. So I just dropped. What side is weak? The right. Okay? Now, this is where things get funky. I don't like this too much, do I? How am I going to compensate? Am I going to compensate by saying like this? Am I going to compensate by doing this number? Am I going to compensate by doing this? Which one? Maybe all of them. This one's a very common one, right? Because what am I doing here? More specific.
Center of mass is over your plant.
Exactly. So I'm taking my center of mass. When I compensate that gait, I'm taking my center of mass and I'm displacing it closer to the leg of stability, aka reducing the moment arm that's happening here. This is where the biomechanics come in. My moment arm right now is this long, from S2, center of gravity, to the center of axis of rotation at the femoral acetabulum joint. Now, I'm reducing it by shifting my body weight. Reducing the moment arm. When I reduce the moment arm, what else do I reduce? Torque, which then requires this muscle to produce less force. I'm sorry? You said what?
Like short and state, like it's getting like closer together, can't be too straight.
So yeah, your gluteus medius will get closer together, we're getting a shortened state, but they're also reducing the moment arm. That's the big one. Reducing the moment arm. So that's the thing I'm also going to have to watch out for, because this is going to happen not only in the frontal plane, right? Because frontal plane hip motion, abduction, adduction. This is also going to happen because gait is a triplanar, three-dimensional, holy cow, there's a lot of stuff moving concept. I'm also going to see these changes and compensations in the sagittal plane. I'm also going to see these changes in compensation in the transverse plane. And this is where gait gets a little difficult. Okay, so that's why we're taking so much time, and we're going to take it step by step, no pun intended. All right, so let's get into the actual hip joint. So first things first, what we need to understand is we need to understand how the hip is put together, okay? Hip is going to be put together primarily by articulation, like I said, between the pelvis and the femur. So what we're going to do here is we're going to draw out a really bad, if it allows me, pelvis. To me, the side view of the pelvis always looks like either an alien from Star Wars or something. Or something out of The Simpsons. Smurf? Yeah, it'll work. So OF is going to be my obturator foramen. This guy here is going to be my pubic symphysis. This is going to be my AIIS. And this is going to be my ASIS. What we're going to see is that I'm going to have very specific muscles that originate off of my ASIS. We're also going to have muscles that originate off of my AIIS. Okay, so it's going to be very important to remember that there's going to be a difference between my ASIS and my AIIS. So first big thing we're going to encounter when I'm looking at the lateral view of my lateral view of my pelvis is going to be that acetabulum. So this guy in the middle is going to be my acetabulum. We're going to see a couple things with my acetabulum. Number one is we're actually going to see a large area that kind of coats the superior, anterior, and posterior aspect. And that's going to be all cartilage. Okay, and this is going to be essentially the labrum, okay, or essentially that labral surface. In the hip, it's called something a little different. This is called my lunate surface. This is where a lot of that force dispersion is going to come in. And this is where a lot of the contact between the femur and the acetabulum has become very important. Also, when looking at the lateral side of my hip, I'm going to encounter, and this is going to become very important in terms of muscle attachment, I'm going to encounter three basic lines. And you guys may have already kind of read about these in the textbook. I'm going to have something called my anterior gluteal line. I'm going to have a posterior gluteal line, and I'm going to have an inferior gluteal line. We're going to draw the inferior in at first. Inferior gluteal line essentially kind of comes off of the AIIS and zips back kind of in that direction. These are going to become very important because what we're going to see is that gluteus medius, gluteus minimus, gluteus maximus are all going to attach at the ilium based on these lines. The anterior gluteal line originates up a little higher, kind of does that. Now, the reason this becomes important is because in this area, in between my anterior and my inferior, this is where gluteus minimus is going to attach. Above or superior to this anterior gluteal line, this is where gluteus medius is going to attach. We're also going to see a line that's in the posterior aspect. And I'm just going to kind of hatch this in. This is where gluteus maximus attaches. And what you'll see, don't expect to go into and look at either one of our simulated bones or one of our live bones, live being a relative term, and see these huge, big, dark lines coming outside of everything. These lines are essentially roughened areas, just like we've seen in other areas of the body, where I'm going to see a lot of attachment. Christina, you okay? In the back?
Like, so where it says gluteus minimus and the next line is that blue?
Let's make, I'll tell you what, let's do this. This one's purple back here. How's that? Much better. That's my fault. Yep, so the purple one is the posterior, the blue one is the anterior, and the orange one's the inferior. That looks better. Oh, thank you. We good? We good now? Okay. I actually appreciate the fact that you look so confused. So I was like, okay, wait a minute. This isn't clicking with somebody. Okay, so I'm not going to ask why you're sitting back there and we have a whole open table here. Okay. I thought it was because there's some sort of weird odor coming off of me or something. Because I noticed like everyone's kind of moved back. It makes me a little self-conscious. So these are really important because this is where life gets a little confusing in terms of the hip. I need to know where these muscles are located. I also need to know where all of these gluteal muscles get their innervations. Because what we're going to see, and we're going to bring in a couple terms that we discussed in the pelvis. So you guys remember we talking about superior gluteal artery, superior gluteal nerve, inferior gluteal artery, inferior gluteal nerve, right? Remember those terms? And I said, oh, yeah, next week after your midterm, we're going to discuss those a little further. Obviously, once I said after the midterm, everyone's like, click, okay, don't need to know that right now. Right? I mean, come on, let's call it duck a duck. Well, now we're actually going to discuss a lot of those terms. So what I'm going to see, okay, and this is an important landmark to remember. Gluteus medius is going to lay over gluteus minimus. The reason that's important is because, as we're going to discuss, gluteus medius and gluteus minimus are going to have the same insertion. Right? So insertion for gluteus medius, insertion for gluteus minimus is the greater trochanter of the femur. Those muscles are going to lay over top one another. What we are going to see, and you guys will see this in cadaver lab, and I want you to be really careful when you dissect this out, is that the superior gluteal artery and nerve are going to overlay and sit literally right in between gluteus medius and gluteus minimus. So when you guys peel back gluteus medius, you should see superior gluteal artery and nerve hanging out right there, almost right on top of gluteus minimus. Okay, and that's really important to know because in terms of dry needling, I need to kind of know where those muscles are. I need to know where those structures are. Yes?
Did you say just the nerve right between?
Artery and nerve. Yep, so it's going to be a neurovascular bundle. Okay, so here's how it's going to go. I'm going to draw it out. Is everyone okay with this drawing? Okay. All right, so here's gluteus minimus on its way down to insert into the greater trochanter of the femur. Superior gluteal artery and nerve are going to sit essentially towards the proximal third, right on top of gluteus minimus. Then gluteus medius is going to sit on top of all of that. Okay, does that make better sense? So essentially what you're going to see is you're going to see these two big fan muscles. Okay, you're going to see this big gluteus medius is going to fan out, and you're going to see this gluteus minimus, which is going to fan out. These muscles are extremely important for a couple reasons. Number one, I'm going to see some big landmarks, right, like superior gluteal artery and nerve. So things like lab exams, that should really help you out. The other big thing, and I want you guys to start thinking about this, and this is where the biomechanics come in, is where those muscle fibers are in reference to the center of the axis of rotation around the femoral acetabular joint. Okay? And this is the big one. If that is my axis of rotation, okay? What's the main motion? What's the main action of gluteus medius and gluteus minimus? Hip abduction, right? Also, you guys may have read this in Graves. Does a secondary action exist? Rotation? Is there a secondary action for rotation? Here's why. And Dr. Justice and Dr. Ty and Dr. Fuller and I were talking about this on Monday after lab. A really interesting thing about the hip that we're going to discuss, I have all sorts of hip flexors, right? Iliopsoas, cool, that's a hip flexor. I have all sorts of hip extensors, right? Gluteus maximus is a great hip extensor, my hamstring's a great hip extensor, cool. I have all sorts of external rotators. Gluteus maximus is a great external rotator of the hip. I'm also going to have 6 deep external rotators, what we refer to in this program as the P-go-go cubes. There is no primary internal rotator of the hip. There's not a single one. So what internal rotation comes from is a huge combination of other muscles doing secondary actions. And how that happens is through a lot of muscle contraction and a lot of muscles working in synergy or symphony, right? So you guys probably learned either from undergrad, maybe a little bit of ex-phys, whatever it is, that we can have synergies, right? And we kind of learn, okay, well, synergy stabilization, cool, and you moved on. This is really where it becomes important, because what I need to start thinking about, if I need my gluteus medius to perform internal rotation, because the anterior fibers, so in other words, the fibers anterior to the axis are going to perform internal rotation, right? We kind of read that in Graves. And actually, Oladis does a nice job explaining it as well. What I will need to have happen here, if I need internal rotation to happen, I need, I'm sorry? Okay. I need to have other muscles prevent its primary motion from happening. Remember, its primary motion is abduction. So I will need muscles that will prevent abduction from happening. What we're going to see is that I'm going to have some adductors, right? Adductor longus, adductor brevis, adductor magnus, that are going to provide some stabilization as well. Luckily, all of those muscles, based on where their attachment is going to provide it actually extra or supplemental internal rotation as well. So what we're going to see, and this is actually one of the kind of the really cool things about the human body, is I can fire some adductors, I can fire some abductors, I fire them together, and I get internal rotation. Or I fire other ones and I get external rotation. Okay, and that's going to become a very big concept, and we're going to talk about this not only in this class, but when you guys take gait and biomechanics or movement analysis next year, you guys will discuss that concept even more. Because where it becomes very beneficial for us as physical therapists, you guys have talked about those hip precautions, right? Cool. So when the surgeon does a posterior lateral approach, what muscles do they cut through?
surgeon's question?
When a total hip replacement is performed and the surgeon uses a posterior lateral approach, what muscles are incised? Gluteus maximus, right? That's the easy one. Some of those 6 deep lateral rotators, right? And we're going to get into the 6 deep lateral rotators here in a second. I'm also going to see, potentially, depending on the size of incision, depending on the direction of incision, maybe some of those posterior fibers from gluteus medius as well, okay? Because we're using a posterior lateral approach. Where's gluteus medius located in relationship to the hip? It's on the lateral side, right? So I need to be aware of, and this is again why these hip precautions, and this is why the anatomy is so important. I need to know what muscles have been cut through. Because let me ask you guys this. If you just had your gluteus maximus sliced through, do you want to start doing a bunch of bridges? Do I need to start doing a bunch of bridges? I need to do some activation, right? How thick is the gluteus maximus? About like that, depending on gluteus maximus. Some are about here, some are about here. It's about in the middle, right? But we need to understand how that surgery is performed, because that muscle will be completely incised. It will be completely cut through. A lot deeper cut than skin surface, I can tell you that. But understand how these mechanics work together. Okay? Yeah.
Will synergists always have opposing actions?
We always have a what action?
Opposing actions.
Not always, but when you sum the vectors together, depending on the motion you want to achieve, yes. But they won't always be completely opposite. What we'll see is, and we're going to definitely see this with like the 6 deep lateral rotators, is that if I have 5 tiny muscles on one side and 1 big muscle on the other side, these 5 tiny muscles and this 1 big muscle may oppose each other, but that's also going to depend on where they attach as well. This is also why we do attachments. So it gets a little more difficult. It does. I'm not trying to make it overly difficult, but it gets a little difficult. All right, so in terms of my femur, big landmarks on my femur, okay? So if I draw out my femur here, and we're just going to draw on the proximal femur. What I'm going to see All right, trivia question. I know that's a very small femoral shaft, isn't it? That person's not going to do very well with weight bearing. Okay, so I was doing some reading before class, and I looked up what the word acetabulum means in Greek. This is by far the weirdest anatomy term I've encountered. Literally, the word acetabulum means vinegar cup. Vinegar, like, balsamic vinegar cup. Yeah, so the original anatomists were like, oh, hey, Chuck, look at that thing. What do you want to call it? I'm like, I don't know. How about vinegar cup? That'll screw with the students. They're like, sure. Yeah, so that's literally why the acetabulum is called acetabulum. It means vinegar cup. I'm sorry?
Can that actually be a trivia question?
Can it ask me, oh, you know what? No. No. I like the random facts. I like the random facts. So what I'm going to see with my femur is I'm actually going to have a very large head. So this whole area here, this is going to be the head of the femur. Just lateral to that is going to be the neck. And then a couple big landmarks. You guys have probably already discussed some of these because they are great landmarks for palpation. This is going to be my greater trochanter. And then if I have a greater trochanter, I'm also going to have a small little bump down here, which is going to be my lesser trochanter. Another big landmark that we're going to see, and obviously there's going to be some other landmarks here, is that I'm actually going to have a line or a crest that attaches my greater trochanter to my lesser trochanter, or in anatomy terms, it goes between those two landmarks. And that's going to be called my intertrochanteric crest. Bless you. Now, the reason I wanted to bring these up is because working in the clinic, especially working in acute care, we're going to see a lot of hip fractures. In fact, in the U.S., there's about 1,000 hip fractures a day. Yep, and about 85% of them come from a fall. So I always tell folks, and I always kind of market PT services in this way, if there's an individual that has a fall risk, get them into therapy, work on their balance, because the average cost of hip fracture from start to finish is around $120,000 to $130,000. So the way I look at it is I can save Medicare, aka I can save the taxpayers about $1.3 million by training 10 patients on balance, right? So if you ever want to look at it like, hey, when someone tells you, oh, PT doesn't matter or PT doesn't have a big impact, that's the size of impact that PT can have. Okay, so believe it or not, community awareness, balance screening, risk, that's going to have wide implications on not only your profession, our autonomy as a profession, but also it's going to have wide implications on the economy as well. Okay, so this is where you really as PTs can have a big impact. Knowing these landmarks are going to be very crucial for identifying hip fractures. Okay, literally I was in the clinic last Saturday, saw a patient, he had a subcapital hip fracture. Okay, so he had a subcapital hip fracture. Now, if you look at the word subcapital, this does not mean that his fracture happened somewhere south of Raleigh or whatever state you're from. Capital is just going to be another word for head. So his hip fracture occurred just below the head of the femur. Right? So if someone is decapitated, they have lost their head. Like I mentioned before, the other thing we're going to see here, and I'm going to bring this up right now, is we're going to have a large vacuum packed, negative pressure, unbelievably strong capsule. And that capsule is going to adhere my femur to my acetabulum, and then it's going to attach in right around the lateral side of that femoral neck. So all this is going to be capsule. The other thing I need to be very aware of here is that I need to know what structures are intracapsular versus what structures are extracapsular. My femoral head and the majority of my femoral neck are going to be intracapsular, aka inside the capsule. Anything, I'm sorry? Yeah, head and neck. Yep, so femoral head, femoral neck, intracapsular. Lateral to all of that is going to be extracapsular. Now, the reason this is very important is because what we're going to see when we start getting into the blood supply that surrounds my hip, it is highly, highly important that I know where that fracture is. Because if that fracture is a femoral neck fracture, if that fracture is a femoral head fracture, if that fracture potentially is an acetabular fracture, if that fracture is subcapital, aka it is an intracapsular fracture, then my patient is going to be at risk for a compromised vascular supply. And what they can get is something called avascular necrosis. Have you guys discussed this one yet? Oh, that's right, Bo Jackson. That's exactly right, Bo Jackson. Now, here's where you as a physical therapist need to recognize that someone is having avascular necrosis. Avascular necrosis does not happen immediately. It takes 7 to 10 days to start seeing avascular necrosis happening. So guess where that patient's going to be in 7 to 10 days after their hip fracture? You're going to be in your clinic. You say dead?
I was just thinking
Jeez.
0 to 100, just like that. That escalates quickly.
So that patient's going to be in your clinic, okay? And this is where, and if you guys remember, I kind of talked, did I tell you guys the story about the shoulder replacement guy I had last semester? Maybe kind of, sort of. All right, well, you're going to hear it again. So here I am. I'm 5, 6 years out of school. I'm ranging this guy's shoulder, and this could happen to a hip. I start hearing snap, 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 right? Like a twig snapping. And I've seen this happen to hips. You're ranging the hip, everything's going okay, and literally you put just enough force through that bone, and it doesn't have the blood supply to keep it alive, and it starts snapping like a twig. You need to be very careful when we're dealing especially with intracapsular fractures, that you're using a little more care with these folks because of the increased risk of avascular necrosis. You have to understand how that's set up, okay? All right, let's go ahead and let's cut it there. I think that's enough for today. And I will see everybody on Monday. Yeah.
What did you say? So everything is lateral to the capsule, that's what you said?
Extra capsule.
Okay.